So, hello all, this is Dr. SJK, your ENT faculty. So, as expected, we have completed the MRB exam. Many are saying that it's a mixed exam. Few are saying very easy, few are saying very tough. But according to me, it's a standard paper. So, not much of completely ditto recall. Few ditto recalls are there, but they have asked a standard paper. Okay, comparing to last time, it's not a standard paper. Second one is Tamil. If you would have read from the Area Plexus app, definitely you would have got at least 30 correct. Okay, so almost all the questions, most of the questions from Tamil were asked from Area Plexus paper only. So, which is indeed a breakthrough. Last year we had a lot of failures in Tamil paper itself, 13,000 students. Now, if you would have subscribed us, definitely that trend would have changed. So concerning ENT, I have given a concise MRB ENT revision book. So we got all the questions from that. Okay, so 3 questions, 3 out of 3 has been asked from this workbook as well as the practice paper we have attached with the workbook. Okay, so first we'll start with the question from here. A place maneuver used to treat. The options were acoustic neuroma. Venous disease, BPPV. The answer is BPPV. So this was discussed in our ENT workbook. See, in the previous paragraph, I have given what BPPV is all about. This table I have given exclusively in the textbook. Diagnostic test of BPPV is Dix-Hallpity, D for D. Therapeutic test for BPPV is Epley's maneuver. Okay, so this was given. So what are the other things that we could know for other options? Acoustic neuroma, we could give radiotherapy, which is a vestibular schwannoma. Venous disease, you could do endolymphatic sac decompression. Glomus tumor, we could surgical excision. So, out of which LPV we have given clearly in our workbook. So if you have read that, you would have answered it very easily. All right. The next question. So 11-year-old boy post adenoidectomy and grommet insertion, unable to taste ice cream. So we have mentioned this particular nerve name at the second page of the ENT text workbook. See, this is middle ear anatomy. At middle ear anatomy itself, I have told you. See, in the anterior wall, that is a canal of Hoogier. This canal of Hoogier is the exit point for carotid tympanic. For example, if this is the anterior wall, so this is the canal of Hoogier. So this is the only nerve from the facial nerve which is exiting out of the canal of Hoogier. So if this nerve comes out of anterior wall, definitely if you are puncturing over the, sorry, this is the tympanic membrane. If you are making a puncture over the tympanic membrane like this, so definitely you would have injured the chorda tympani. Now, it's no brainer. It's such an easy question. So if you would have listened to the class carefully, you would have easily answered it. So why not other option? This tympanic plexus and Jacobson nerve both are over medial wall of middle ear, which again I have explained in the workbook. This facial nerve is along the facial canal. So a minor procedure like adenoidectomy and grommet insertion and all cannot injure the chorda tympani nerve. It's very well clear. So chorda tympani nerve supplies the anterior 2/3 of tongue taste sensation. So second question went like this. So it was very well clear that. So the second page of the ENT workbook itself, we had this. Okay, fine. Then the next question. Vidian neuroptomy is done for. The options given were allergic rhinitis, atrophic rhinitis, vasomotor rhinitis, fungal rhinitis. The exact word vasomotor rhinitis was not given in our workbook, but I'll come to that. The treatment for atrophic rhinitis, I've told you very clearly, it could be either Young's procedure or it is modified exposure. So atrophy is a disease where there will be atrophy of the turbinates with the roomy nasal cavity, greenish crusting, merciful anosmia. So one option you have successfully ruled out. The next question. So fungal sinusitis, I've told you, you should not do any other conservative management. The surgical management of fungal sinusitis is FIS, which is functional endoscopic sinusitis. So this screenshot I've taken from the written notes of the PDF which I took for MRB. Okay, so that's the one. So allergic rhinitis, I've told you, you know very well, the treatment could be steroids, either mainly topical steroids. Okay, you know very well about that. Okay, now if you would have answered our MRB practice paper, we have clearly given this question. Vidian neurectomy is for, it's a repeat question, is for vasomotor rhinitis. So vasomotor rhinitis is a sympathetic overactivity due to sympathetic fluxes coming out of the Vidian canal or nerve to derigot canal. So at that canal, we will be having a sympathetic nerve which is supplying the nose. If we cut down the sympathetic plexus, okay, the patient can get rid of the sympathetic symptoms. So which is a clear-cut feature of Vidian neurectomy. Okay, so Vidian neurectomy, which is a parasympathetic nerve. Okay, so I'll explain that. This Vidian canal will be having sympathetic nerve of deep petrosal nerve. Okay, then there will be greater petrosal nerve. So this one is a parasympathetic one. This one is a sympathetic one. Okay, so both are coming through the Vidian canal and is supplying the nose. So this parasympathetic is mainly for nasal secretion. This is for sympathetic supply of nasal cavity. So in vasomotor rhinitis, there will be too much of secretions from the nose. So if we do a neurectomy over here, which aims at cutting down the parasympathetic supply. So if we cut down the parasympathetic supply, there will be relief for the patient with too much of nasal secretion. So this one we have clearly given down in the practice paper. So Vidian neurectomy is done for vasomotor rhinitis. Okay, right. So that's all about the 3 questions that we had under ENT in MRB. Thank you.